Welcome. So today we want to continue our discussion of the endocrine systems, the general concepts of the endocrine systems. And today we want to talk about two specific things. That is the assessment of the system and its pathology, the way you classify the pathology. So first we want to explain then the principles and the limitations of how we measure the hormones. And this is done in two ways. One is by actually quantitating them, and secondly, asking whether or not they're active. And then secondly, we want to explain the classification of these endocrine pathologies. So assessment of function. So as we said the last time we were in here, that if we have too much hormone, then we have a hyper secretion of the hormone. We have hormone excess. And the problem with this situation is that you can have downregulation of the target cell receptor. So we could desensitize the system so that it's not recognizing and it's not giving us the biological activity. Or we can have a really, really strong response. And so we have an over-response to the amount of hormone that's being available. The second was that we have too little concentration of the hormone. We have hyposecretion of the hormone, and this would be hormone insufficiency, where not enough of the receptors on the target cells are occupied, and we don't get the biological effect that we need, or the biological response that we need. And then we said we could also have target cell resistance, and this is a problem where the receptors on the target cells are unresponsive. And they could be unresponsive because they're uncoupled, so they're still present on the cell surface. This is what we see with diabetes type 2 individuals often. Or we have the receptor is actually removed or degraded, and so it's not even present on the cell surface. And then just right is a normal or eusebio secretion, and that's where the hormone system, the endocrine system, is working correctly. So we have two assays for measuring our hormones, and one of them is called competitive binding assay. And remember that the hormones are at very, very small concentrations within the blood. So we have to have a very sensitive assay to find the amount of hormone that's within our sample. And to do this, we use a specific antibody. So this antibody then recognizes the hormone. And we have in our system, in the assay, we put in a labeled hormone. So we have a known amount of labeled hormone that would bind up all of the antibody that's within the system. We mix this with a hormone that's from our patient or from the unknown. We don't know the amount of hormone that's here. So this is our X amount. And we mix this then with the known or labeled hormone and our antibody, and then assay for how much of the hormone, the labeled hormone, has been brought down. And the unlabeled hormone should compete a finite amount of the labeled hormone, and then by subtraction we know how much it should have come down. By subtraction we can figure out how much of the unlabeled hormone we have present in the sample. So this is high sensitivity because of the antibody, and it's high specificity because of the antibody. But it doesn't tell you if the hormone is active. So when could this give us a false reading? So let's say you have an individual who presents as if they are diabetic type 1. These individuals have very high circulating levels of plasma glucose. They have high circulating levels of plasma glucose, but when you assay for the insulin in their bloodstream, you find that insulin is also present. So by this competitive binding assay, the insulin is present. So the question is the insulin that they're making functional? And so the way you test that would be that you would give this individual some insulin that you know is functional and see whether or not the amount of glucose that's circulating in the plasma will decrease. If it does, then you know that the insulin that the individual is making an insulin that's not reactive. It cannot bind to the receptor, or it has some problem in its structure. So we have to have a second assay then, which tells us whether or not our hormone is functional. And these are called bioassays. So what I've diagrammed here is a complex negative feedback loop of one of the hormones that we'll talk about later on in the course. But this particular hormone is cortisol, and it's secreted by the adrenal gland. This hormone is secreted in response to a low plasma glucose. So we have low plasma glucose, then the hypothalamus, which is an area of your brain, will secrete a hormone called CRH, or corticotrophin. This hormone binds to a second area of the brain called the anterior pituitary to secrete ACTH, adrenocorticotrophin. This hormone works on the adrenal cortex to cause secretion of cortisol. So that's our regular stimulation of the cortisol from the adrenal gland. Cortisol happens to be a steroid hormone, so it takes about 30 to 60 minutes before cortisol will rise in the blood. And the reason for the delay is that cortisol is a steroid derivative, so it has to be synthesized on demand. And then cortisol is secreted into the blood and delivered it binds to a carrier, and then it's delivered to its target tissue. The cortisol will feed back in a negative manner to turn off the secretion from the anterior pituitary and from the hypothalamus. And this is a complex negative feedback loops that we saw when we were talking about homeostatic controls in the first lecture. So what happens if the cortisol that's in the particular individual is very, very high? So we have very high levels of cortisol, and because we have high levels of cortisol, we will actually have very high levels of plasma glucose. And the individual is coming into the physician's office because of the symptoms that this very high cortisol is causing within his body. So this high cortisol should have fed back and turned off ACTH and turned off CRH. But it doesn't seem to be, it's too high. So the question is, do we have a tumor that's making this cortisol, or do we have too much of this ACTH, which is pushing the synthesis of the cortisol? So is the problem occurring here at the ACTH level, or is the problem occurring here at the cortisol level, at the adrenal itself? So to test this axis, then, we run a suppression test. And this is that we give a drug called dexamethasone, which inhibits the synthesis of ACTH by pituitary cells. When we give this drug, after we administer the drug, the ACTH levels should fall. And when the ACTH levels should fall, then the cortisol levels should also fall. So if we had a very high amount of ACTH, then we turn off the ACTH, the cortisol should fall. If the cortisol does not fall under these conditions, then the question is whether or not the ACTH has gone down. And you could then assay for the ACTH. If, on the other hand, the cortisol does fall, and the ACTH, let's say the ACTH under those circumstances did fall, but that the cortisol stayed high, that would tell you that there's a problem with the adrenal glands, or that there's a problem with a tumor someplace in the body that's secreting cortisol, that's not under the regulation of ACTH. So this is a way, then, that we can sort of parse the axis to find out exactly where in the axis our problem lies. Let's look at a case where we have the opposite, where we have low cortisol, we have low cortisol levels. The hypothalamus secretes CRH due to the low plasma glucose, and we should have ACTH, but we have low cortisol. We can give this individual ACTH, so exogenous ACTH, to push the axis to see whether or not the adrenal is working. And when we do that, then the cortisol levels should rise. We wait 30 to 60 minutes, and we should see a rise in cortisol. If the gland, the adrenal gland, is working correctly, then the exogenous ACTH should correct the situation. We should see a rise in cortisol. That then tells us that there was a problem with the anterior pituitary, that it was not secreting ACTH correctly, or there may have been a problem with the CRH, which is then there was a decrease in the ACTH. So at that level, then, you would have to go back and look to see whether ACTH and CRH levels are appropriate. So how would you classify these endocrine pathologies? So the endocrine pathologies, then, in the situation where we have this complex negative feedback loop, we have a primary pathology if the last endocrine organ is not working correctly. So in our case, we had low cortisol, and that endocrine organ was the adrenal cortex. If we have low cortisol, what we should have seen, if the problem is sitting here, then what we should have seen is that ACTH levels would be high and CRH levels would be high, that the system would be trying to push to get an increase in the cortisol. On the other hand, and we don't have a negative feedback loop to decrease the ACTH or the CRH because the cortisol level is low. If the problem was secondary, then we'd have a low cortisol, but we would also have a low ACTH. The ACTH is the problem, and that means that the problem is sitting here at the pituitary. The CRH then could be high because the CRH is trying to push the ACTH, but the ACTH is not being secreted correctly. It's low, and therefore cortisol is low. That would be classified as a secondary pathology. And if the problem is occurring at the level of the hypothalamus, then this is a tertiary problem where we have low cortisol, we have low ACTH, we have low CRH. The entire axis is downregulated. And the entire axis is downregulated, we are missing the CRH. In these individuals, then, the individual can be given ACTH. By giving them ACTH, we then can move the cortisol levels up because the adrenal gland was working correctly. So these pathologies, then, as you're looking through these different problems, and we want to see whether or not what these different pathologies are, and to be able to classify at what level the pathology is occurring. This is a misspelling. All right, so what are our general concepts? Then first of all, we have pathology in endocrinology occurs when there is either too little or too much hormone, or we have a resistance to the hormone due to receptor dysfunction. And secondly, we can interpret the hormone levels, and as we're interpreting the hormone levels, we have to consider the trophic hormones that are above it and or the level of the nutrients which are controlled by the hormone. And so in the case of a complex negative feedback loop, we have to consider all of the hormones which are within that negative feedback loop as to whether or not they may be the problem. And you start with the primary and then work backwards. But you have assays where you can assay the amount of, for instance, we could assay the amount of ACTH, we can assay the amount of cortisol. But you start with assaying the amount of cortisol and then go back and see whether or not there was a problem with the ACTH. So I hope this makes sense to everybody. You should go ahead and try the problem sets because this will allow you to apply what you've learned from these various concepts in endocrinology to actual cases and see whether or not you can think through these cases. Okay, so see you next time. Bye-bye.